Are we on?
We're on.
We're on. Hello, online friends. Thank you so much for joining, everyone. Really appreciate it. Appreciate everyone who made the trip out to Medipause, particularly in the horrific rain. Thank you very much. And appreciate your patience in waiting for the pizza. To all of our friends online, hello in cyberspace. So we've got a couple of really wonderful speakers tonight. We've got the lovely Frances Laithwaite, who is our lead anaesthesia nurse. And we've also got Melissa May Coleman. I just learned her middle name. She also goes by Mel Coleman. So Mel's one of our senior surgery nurses, so also very well into the anaesthesia side of life. So yeah, we hope you get a lot out of tonight. We're going to be running a whole stream of CPD events throughout the year. So we would love your feedback afterwards. Anything that we can be doing better or any topics that you're really interested in is really, really useful. And for all of our in-person participants, you'll find that you've got a little gift here on the way out as well. So they're kind of a collect them all sort of gift. So the more things you come to, the more little things you'll get. So yeah, so I hope you all enjoyed. And without further ado, Frances.
Can we hit the lights so we can see what we're looking at? Alrighty. So, hi everyone, and welcome to our first Medipause education event of the year. As Kelly just said, and also we're making it into a series, and we've got lots of exciting topics coming up that a lot of nurses are working really hard on. So we hope to see you all at the next one. Keep your eyes peeled for our emails. My name is Frances, and as Kel said, I'm the anaesthesia nurse at Medipause, and tonight I'm going to be going through the respiratory system, and then afterwards Mel is going to talk about capnography. So let's get started. So what we're going to cover tonight, we are going to cover why the respiratory system is so important, some anatomy and physiology. We'll also have a quick chat about the mechanics and control of respiration. And we'll have a quick look at lung volumes and cover a few of the common phrases that you might hear when we talk about lung volumes. And lastly, we'll move on to how we can clinically assess the respiratory system in our patients and what we do consider respiratory emergencies. So why is the respiratory system so important? So the respiratory system is responsible for breathing, which is the process by which oxygen is delivered by the respiratory system into the bloodstream and circulated to the cells around the body. It is also the way that waste gas, so our carbon dioxide, is expelled from the body. The removal of the carbon dioxide is also one of the ways that the body maintains an acid-base balance. In animals, breathing also helps them thermoregulate. So especially in our dogs, when they pant, they can expel body heat through this. And as we will talk about a bit later, if cats are panting, that's not kind of the same thing. And we should take that pretty seriously immediately. But dogs panting, normal, as we all know. And the fourth is for smelling, basically, olfaction. So the anatomy and physiology. So the respiratory tract, it's basically comprised of our upper respiratory tract and our lower respiratory tract. So we'll start with the upper and work our way down. And I can see someone's waiting in the lobby, and I'm going to have to flip through screens, and I'm not good at IT, and I can't do it. Mel, can you just jump on and see if you could admit someone from the lobby into the chat? Thank you. So we will start with the upper respiratory tract. The upper respiratory tract starts with the nose and mouth that leads into the larynx, pharynx, and then the trachea. The nose and mouth are responsible for warming and humidifying the inhaled air before it reaches that lower respiratory tract. So the first part is our nose. The nose has two different functions. respiration, and olfaction. Inspired air enters the respiratory system through the external nares, which then leads into the nasal cavity. The nasal cavity is divided by the septum into a left and right nasal chambers. The entrance of the nasal cavity is also protected by a hairless pad of epidermis, which is supplied with mucus and sweat glands. Tea. So the nasal chambers are filled with tiny fine scrolls of bone called turbinates. These turbinates are covered in ciliated mucous epithelium, which is well supplied with blood capillaries, and their function is to humidify the air being passed over them. The cilia and the mucus trap any particles that are present and then transport them to the back of the nasal cavity where they pass to the pharynx and are swallowed down, preventing them from entering the lower respiratory tract. And the inspired air that our patients then breathe in is therefore warmed, humidified, and free from harmful particles before it reaches the lower respiratory tract. The next part of our respiratory tract is our pharynx. This is a region at the back of the mouth that is shared by the respiratory system and the digestive system. It's also divided into the nasopharynx and the oropharynx and is divided by the soft palate. The soft palate is there to prevent food from entering the nasal cavity and yeah, I don't know why I'm trying to say something that I'm not supposed to. So then after our pharynx is our larynx. So the inspired air enters the larynx. What is with my clicky? Sorry, I'm not very good at IT if you haven't noticed. Inspired air enters the larynx, which lies caudal to the pharynx between the two halves of the mandible. And the function of the larynx is to regulate flow of gases into the respiratory tract. The larynx is suspended from the skull by the hyoid apparatus, which is a hollow box-like structure that consists of cartilage connected by muscle and connective tissues. Most rostral of cartilages is the epiglottis, which is an elastic cartilage that's responsible for sealing off the entrance of the larynx when swallowing is occurring, preventing choking on food or saliva. Within the larynx is a pair of vocal ligaments. The mucous membranes covering the inner surface of the vocal ligaments form the vocal cords, which project bilaterally into the lumen of the larynx. And our patients make sound when air moves past the vocal cords and they vibrate. Cats do have a very sensitive larynx and can be very prone to laryngeal spasm, just on a side note. And then the final part of our upper respiratory tract is our trachea. The trachea is a permanently open tube that is attached to the caudal border of the laryngeal cartilage, and from the larynx air enters the trachea. The lumen is kept open by a C-shaped ring of cartilage, which extends the length of the neck, passing through the cranial thoracic inlet. In the thoracic cavity, it terminates at the bifurcation above the heart. The cartilage prevents the trachea from collapsing when the thoracic pressure falls. However, the incomplete rings, so those C-shaped rings, allow for food to go down the esophagus unimpeded by those tracheal rings. The trachea is also lined with a ciliated mucous epithelium, and the surface of the mucus, very much like in the nose, traps any foreign particles, and the cilia then sweep the particles up and outwards. And so it's like coughed out, where it can go into the pharynx and then be spat out or swallowed. So we don't have anything entering our lower respiratory tract. So after the trachea, we then end up in the lower respiratory tract. It is comprised of the bronchi, the bronchioles, and the alveoli, all within the lungs, and all which are found in the thoracic cavity. So the thoracic cavity contains both the left and the right lungs, as well as the heart, associated vessels, and trachea and esophagus run through the thoracic cavity as well. The lungs lie in separate cavities known as the pleural cavities. The pleural cavities are divided by a double layer of connective tissue called the mediastinum. Each pleural cavity is lined with a pleural membrane that secretes a small amount of serous watery fluid to reduce friction between the pleural surfaces when the lungs are inflating and deflating during respiration. Most of the organs, so the heart, trachea, esophagus, the associated vessels in the thorax lie in the space between the two layers of mediastinal pleura. The bronchi and the bronchioles. So the trachea bifurcates into the left and right bronchi. These bronchi are supported by complete rings of cartilage, unlike our trachea, which was C-shaped rings. These are complete rings of cartilage. And they enter each of the lungs as they enter the lung tissue, and then the bronchi divides into smaller and smaller branches. As the branches become smaller, the cartilage support gradually diminishes and disappears completely, at which point the passages are called bronchioles. Bronchioles continue to branch into smaller passages. The smaller diameter of the branches, the smallest diameter of the branches are known as alveoli ducts, and that leads into the alveoli. The walls of the bronchi and the bronchioles are smooth muscle and under control of the autonomic nervous system. This allows the airways to dilate to enable more air to reach the lungs during exercise and constrict back to the original size during normal respiration. So our lungs consist of air passages, blood vessels, and surrounding connective tissues. Only the most proximal parts of the bronchi are located outside of the lungs, and everything else is within the lungs. The lungs are enclosed in the pulmonary pleura and divided into well-defined lobes. The left side has 4 lobes, and the left side has 3 lobes, and the right side has 4 lobes. So our alveoli, the alveolar ducts end as alveolar sacs, and in each alveolar sac consists of large number of alveoli, all surrounded by capillary networks. Our alveoli are very small, thin-walled sacs. The epithelial walls are thin and allow gaseous exchange with the blood to take place. There are millions of alveoli in each lung to provide a large surface area in which gas exchange can happen. The alveoli are the only part of the respiratory tract that are involved in gaseous exchange. The rest of the tract is referred to as anatomical dead space. The function of the rest of the tract is just to conduct the gases to and from the area where gaseous exchange can happen. So here's just a nice little diagram of how the alveoli kind of looks with the capillaries. So the oxygen of the inspired air diffuses across those pulmonary membranes into the bloodstream within the capillary bed of the pulmonary circulation. And then simultaneously, it's exchanged with waste carbon dioxide, which is in the blood brought back from the body, and then that's expelled from the lungs within the expired air. So we're just going to have a quick look at the mechanics of respiration, and I appreciate this is a human picture, but it was the best one that I could find that kind of explains how it works. So the mechanics of respiration, also just referred to as breathing or pulmonary ventilation. So respiration is achieved by a coordinated series of actions carried out by the respiratory muscles, resulting in alternate expansion and reduction in the volume within the thoracic cavity. There are 3 sets of respiratory muscles responsible for respiration. So we have the diaphragm, which is a dome-shaped muscle that forms boundary between the thoracic and the abdominal cavity. And it is innervated by the phrenic nerve, which arises from the cervical spine. When the diaphragm contracts, it flattens, and that increases the volume of the thoracic cavity. Secondly, we have our external intercostal muscles that fill the spaces in between the ribs. These are innervated by the intercostal nerves, and as they contract, they lift the ribs upwards and outwards, increasing the volume of the thoracic cavity. And thirdly, we have the internal intercostal muscles that fill the intercostal spaces and lie deep to the external intercostal muscles and are also innervated by the intercostal nerves. These muscles are mainly passive, but during forced expiration, they contract along with the abdominal muscles to force air out of the thoracic cavity. So during inspiration or inhalation, the diaphragm and external intercostal muscles contract. This causes the volume of the thoracic cavity to increase, and the pressure in the pleural cavity falls, and the lungs are pulled outwards, and air is then sucked into the trachea and into the lung tissue. And then during expiration or exhalation, it's very much a passive process for the most part, but the diaphragm relaxes, regaining that nice dome shape, and then the external intercostal muscles relax and the ribs drop downwards, and then the volume in the thoracic cavity decreases, the pressure in the pleural cavity rises, and the lungs collapse, and the air is pushed out of the trachea. And next, we'll just have a look at the control of respiration. So respiration is controlled by the respiratory centers in the pons and the medulla of the hindbrain. The pneumotaxic and I'm going to struggle with this word tonight. Apneistic centers control expiration, which is mainly passive action, but some impulses from these centers can assist in the expiration. The inspiratory center controls inspiration. Impulses travel down the phrenic nerve to the diaphragm and to the intercostal muscles via the intercostal nerves. These centers do inhibit each other, so cannot work simultaneously. So that's how they manage to keep the basic rhythm of respiration, because if one's working, the other is not. And the rate and depth of respiration is controlled by receptors found within the body. These are our stretch receptors, which lie within the walls of the bronchi and the bronchioles, and monitor the degree of stretching within the bronchial tree. When the lungs are distended, they send impulses to the respiratory center to inhibit any further respiration, and expiration is triggered by the apneistic center. And then we have our chemoreceptors, which are found peripherally and centrally. So the peripheral are found in our aortic bodies located in the aorta close to the heart, and the carotid bodies found in the walls of the carotid artery. And then the central brain chemoreceptors are found in the medulla of the brain. Both chemoreceptors monitor oxygen levels and the pH of the blood, as high CO2 levels in the blood lowers the blood's pH. So when this is noticed by the chemoreceptors, they can stimulate an increase in the rate and depth of the respiration. So we're just going to have a quick look at lung volumes. So I don't know if anyone's seen this diagram before. No. So this is basically a diagram that shows the full what our lungs can fully do, but our lungs will never get rid of that tiny little bit at the bottom that's residual volume. So I'll just quickly chat through it a little bit. So when we breathe, we only use a really, really small portion of our lungs. So we're really only using where the little red line is going up and down. So the air that passes in and out when we're just breathing at rest, that's called our tidal volume. So if you just see that little red line and then go across, you can just see it says tidal volume there. So when we're breathing, we're literally using that much of our lungs. We do not use a lot. More air can be inhaled if we force an inhalation, which you can see with in the top yellow box. So our inspiratory capacity can go up to there, but that's only if we really kind of go and forcing a breath. It's not our normal breathing. And oppositely, you can force exhale more air than what is needed, known as the ERV, or the respiratory reserve volume, and that's where it comes down. We will always have some air left in our lungs, and that's called our residual volume. It just keeps like all our alveoli open and everything working nicely. It should never kind of empty out at all. So tidal volume, we'll just go really basic, just a couple of little can't think of the word. Anyway, tidal volumes is the amount of air that moves, definitions. The amount of air that moves in and out of the respiratory system in one breathing cycle, which is one breath. And that tends to be, in our patients, 10 to 15 mils per kilo. And our minute volume or minute ventilation is the total air inhaled and expired within 1 minute. So you can work that out by either multiplying your patient's body weight by 10 or 15 and then timesing it by their rest rate, and that will be your minute volume. So our normal respirations for cats are 20 to 30 at rest, and normal for dogs, depending on size, 10 to 30 at rest. Does anyone have any questions about that? It's a nice diagram. It's a very nice, I like this diagram. So let's move on to the clinical assessment of our respiratory system. So what should we monitor when we're monitoring respiration? We should obviously monitor our respiratory rate. Is the rate elevated? And we also look at our respiratory effort. So what is our respiratory effort like? How are they breathing? Is there an abdominal component to the breathing? Are they doing an orthopenic position where they're kind of standing with their elbows out to maximize kind of the chest expansion? Do they have their neck extended? If patients are really struggling, they'll usually like have a reluctance to lay down, can be open mouth breathing, restless, can also be key indicators that the patient is struggling to ventilate. And as I mentioned earlier, open mouth breathing is considered very much an emergency and should be treated rapidly. We also need to check our mucous membrane color. Our mucous membranes are normally pink, but are they blue or cyanotic? Are they brick red? These can all indicate that there are respiratory problems. And then we also need to do a thoracic auscultation. So when we're auscultating the thorax for our respiratory system, we're trying to listen out for crackles, which can indicate that we have fluid, or wheezes that can indicate that we have narrowed airways. Muffled sound or silence can indicate maybe a pleural fusion or a pneumothorax as well. And then we'll finally, from me, look at what we consider a respiratory emergency. So our respiratory emergencies are dyspnea, upper airway obstructions, I've got these the wrong way around. No, laryngeal paralysis, pleural effusion, and pneumothorax. So our nursing priorities at this time is to provide oxygen first and do the diagnostics second. Try to use minimal handling as it can increase stress. And we should also prepare our emergency drugs and intubation kit if we're faced with any of these during when our patients come in. And that is it from me. Is there any questions at all? I think I flew through that quite fast. I'm a fast talker. Alrighty, maybe we'll turn the lights back on and have a bit of pizza, and then Mel can do her side. Oh, Jesus. The light is aggressive. For everyone who's just online, we're just going to just pop the mic off. We'll just probably have a 5 to 10 minute break while the guys here just have some pizza, and then we'll be back on. So keep listening, go grab yourself some food. Hello, everyone online. So we're going to get started now with the lovely Melissa Coleman. So take it away, Mel.
Thanks. Hey, everyone. So we are going to talk about capnography now. So after Francis's great talk on the respiratory system, now we're going to see kind of what we're dealing with when our patients are under anaesthesia and kind of how to troubleshoot things and things like that. So we are going to cover what is capnography, why it's so important in our patients, our normal and our abnormal waveforms, and how to troubleshoot some things as well. So to start off with, what is capnography? So capnography measures our end tidal carbon dioxide, which is also known as ETCO₂, and it's a real-time measurement. It's continuous, non-invasive. It provides us a trace as well as a number. And our venous and expired CO2 are highly comparable. So if we were to take a blood gas of our patient, our end tidal CO2 and our venous CO2 should be very, very similar. The best thing about capnography is this allows us to assess our ventilation breath by breath, and it can provide further information on our circulation, any respiratory issues, and its their status in general. So why is our capnography so important? So it's not just about our breathing rate, but it gives us information about our airway, breathing circuit, and even circulatory issues. It confirms our airway and ET tube placement. So once we've induced and put a tube in our airway, it makes sure that we are actually in our trachea and not in our esophagus. It monitors our ventilation so we can notify us of any issues before they arise. It gives us an indication of our circulation and perfusion. So if our end tidal CO2 is low, then we are going to be worried about any circulatory issues or even perfusion issues that's going on in the body. And it's critical in CPR for return of spontaneous circulation as well. And it improves our patient safety. So there is two types of capnography. So we have mainstream. So this is where the sensor goes. I'll put a laser on this. So this is where the sensor actually goes between our breathing tube and the circuit itself. And this is kind of what it looks like. And then we've also got our side stream. So that this is where there's an extra port on. So as you can see here, this is just an extra connector or an elbow connector if you've ever seen one of those, or you can use it via HME as well. So with our mainstream capnography, it's got some advantages and it's got some disadvantages, but our advantages are it's a rapid response. So because it is connected to our patient's ET tube, it is an almost instantaneous waveform and number. It is slightly more accurate with our tiny patients, especially with our little cats or our like neonates and puppies and kittens and things, because they have smaller tidal volumes. And then we've got our disadvantages. So it can malfunction with water vapor. So these sensors are highly sensitive, and any water vapor which naturally comes from our patients because they're generally warmer than our outside temperature, so they can get damaged quite quickly and they're very, very fragile. These can be quite big as well. So if you do have your smaller patients, it does increase our dead space. So it's just something to be mindful of. And it also adds weight to our ET tube. So if you do have patients in a strange position or anything like that, you just need to be very mindful that these do weigh down the ET tube. So it could potentially extubate your patient if you're not careful, or potentially cause a kink. And then we have our side stream. So our advantages of this is there's not as much extra weight. The HMEs are very, very light, or the small connectors, again, are very, very light. And then it helps with our dead space. They're not generally as big a sensor as our mainstream ones. And the very expensive sensor is away from the patient. So we have, if you can, the image to the right, this is kind of what they look like on a machine. So this blue kind of thing is called a water trap. So any water that goes through the sampling line gets trapped in there, so it doesn't go into the sensor, and it just helps it last that little bit longer. And then there's minimal dead space. Our disadvantages of this is it's a slower response time. So depending on your machine, it can be a 3 to 10 second delay. So what the machine does is draws the air out, essentially. So that's why there's a delay. The sample line can occlude. So if there is any moisture or water vapor, that can get trapped in the line. And this can mean that they need replacing, as well as that water trap as well that does need replacing. And the sample the sample, because it is taking out the oxygen and the ISO, it does need to have scavenging on that as well. Otherwise, we're going to be putting ISO into the air. Just a fun little tip as well. This was a patient that I had. It was a tiny little puppy. He was 6 weeks old. I think he weighed 500 grams, and we were really struggling getting capnography. So what we did was, at the end of the ET tube, we actually put a pink needle through it, and then that acted as our sampling line. So if you ever have these really tiny puppies, kittens, you obviously then have to get rid of your ET tube at the end, but it gives you a really good way, because he was just too much dead space with any of the connectors we had in the hospital. So it's just a little tip that you can do on your tiny patients. So how does the machine measure CO2? So carbon dioxide is absorbed by infrared light. So a sample of the gas that's being inhaled and exhaled by the patient is passed through the chamber via the side stream or the mainstream route, and it is shone through the chamber. The greater the amount of carbon dioxide, the higher the infrared light is absorbed. And then that measures the CO2, which then gives us a waveform and a number. So as you can see by these two pictures, especially the one at the bottom, even though it is a human, on the side stream, it just goes through, a part of the gas is taken out, all the infrared light bounces through it, which then creates our number, which is highly important to us. So our normal end-tidal CO2 values, we have got, Francie, there's someone that's just joined. Do you mind admitting them? It should come up on my phone. So our normal end-tidal CO2 values are slightly similar in cats and dogs, but our cats can go as low as 28 and as high as 38, and our dogs is 35 to 45. And as I said before, our end-tidal CO2 closely reflects our arterial and venous CO2. It's really important to notify our trends, and it's more important than a single value. So what are we looking at? So this graph is going to explain everything. It's going to be very, very wordy. So if you do want me to stop and explain anything, please just let me know. But it is very crucial to understand the normal before we recognize the abnormal. So this is probably like the most perfect capnograph you would ever want to see. So we have phase 1, which is this respiratory baseline. This is representing the resting phase, or the beginning of our exhalation. This is the gas that is coming from the anatomical dead space in our lungs, so our trachea and our bronchus. This is where no respirations occurs, and it should always be at 0. If it is any higher than that, the patient is rebreathing, but we will explain a little bit more about that later. Then we have our expiratory upstroke, which is phase 2. So this is this sharp line that's coming up on the left here. This is a transition from our dead space to alveolar gas. And this is where the CO2 is mixing with the dead space gas, and it causes a sharp rise in CO2. This is the normal upstroke that's shown. It should be steep and smooth. If this phase is prolonged or slanted, it can mean an airway obstruction or resistance, again, which we will touch on later. We then have phase 3, which is this alveolar plateau. This is predominantly from our alveolar gas that has been exchanged from all the vessels, and it's our most accurate representation of the patient's ventilatory status. If there is a sloping downwards or an uneven plateau, it could be a sign of airway disease, leaks in the system, or other issues as well. And this is where our measured end tidal CO2 is. So it's a very steady plateau, and then where this dot is here is where we are getting our end tidal, because it's the end of the tide, like end of the tidal volume, and that is where our CO2 is being measured. Then we have our phase 0 or inspiratory downstroke, and this is where the waveform should rapidly drop back down to 0, and this is the patient then breathing back in again. So again, all of our carbon dioxide should be decreasing because oxygen is entering the lungs, and it should again go back down to 0. And if there isn't, then it means our patient is rebreathing CO2. Does anyone have any questions on that? Because that's quite a lot of talking. Actually, great. So on our machine, it can look like this in a couple of ways. So our top image is very similar to what we saw on our image that we just had. And then the bottom image is also relatively normal. It's just a faster rate, and it's also from a cat. Cats can have ever so slight different waveforms, and it doesn't look as nice as the top one, but it's breathing quite quick, so it's why it kind of looks a bit not as normal as the first one. So just going over basics of what happens if we're hypercapnic. This number is from a real patient. This is from a dog who was very hypercapnic. And then 57 as well is like our borderline as well. It's higher. This was from a dog. It's higher than our 45. We would kind of tolerate it, but it's not that great. So if our patients are hypercapnic, they have increased PaCO2, again, which is the amount of carbon dioxide in our arteries. And it stimulates our sympathetic nervous system, and all of these it can cause respiratory acidosis, and it can lead to increased heart rate and blood pressure. We have cerebral vasodilation, so it increases cerebral blood flow and intracranial pressure. If you're worried about any patients having any brain issues or traumatic brain injuries, potentially even a brain tumor, we want to keep this as low as possible because it actually makes our brain perfusion not as well. And in severe cases, because the body goes into an acidosis, it can cause cardiac arrhythmias and reduce cardiac output. And this is because the blood changes the channel functions across the heart, and it can disrupt normal depolarization and repolarization of the cardiac cells. That only happens if you've been hypercapnic for a very, very long time, but it's just something to note that it can happen and it can cause some issues. And then what happens if we're hypocapnic? So this occurs when the CO2 in the blood falls below normal. It's generally because of excessive ventilation, either by the patient breathing too quickly or if we're manually ventilating it, that can happen as well. So this is causes decreased PaCO2, so the amount of CO2 that's in our arteries, causing to respiratory alkalosis. It then causes cerebral vasoconstriction, so that's reduced cerebral blood flows. It narrows the vessels in the brain, and then that causes less blood flow to the brain. It can cause decreased oxygen delivery to the tissues, and we get cardiovascular depression from this. So it reduces our cardiac output, can cause some hypotension, and then it causes reduced venous return, and then that is why there's less CO2 being released in to the tissues. So we've got quite a fine balance. Obviously, we've only got about 10 with our cats and dogs of what normal is. So we just need to be very careful when if we're ventilating our patients, and it just shows why our capnograph is so important. So we're going to go through some common traces now. I'm going to put some traces up on the screen, and I'm going to kind of quiz you guys on the spot, but we will go through them. So does anyone have any idea what this could mean? Both. It's the same one. So what does it look like? So we've got obviously this number here. So what do we think of that number? Is it good or is it bad? It's very bad. Yes. We don't want it that high. And then this top picture here, so we can see that our end tidal CO2 is rising. So this is hypoventilation. Now it gets quite complicated because the patient here is hypoventilating, but we are hypercapnic. And it took me a while to get used to it. The elevated CO2 is hypercapnic, and this is where the end tidal CO2 is gradually rising. So yeah, elevated CO2, hypercapnic. It's generally when they have a slower respirate, but it also can be anesthetic depth related. So if your patient is too deep, you will see them getting hypercapnic because they are not breathing as well. And it also, because our anesthetic agents suppress the activity of the brain stem where our respiratory center is, that is why this happens. So the brain becomes less responsive to our CO2 levels, meaning they can build up. So generally, as I said, the causes are deep anesthesia and central nervous system depression. To treat this, you would start trying to reduce your anesthetic agents. And then if that didn't work, then you'd start manually ventilating, whether it's by hand or if you've got a ventilator. So then on to our next one. What do we think about this? So in this top image, what is happening this time? Yeah, perfect, hyperventilation. And as you can see in the bottom image, so even though we are hypercapnic in this, we are breathing quite fast and we have slightly different peaks as well. So yes, this is hyperventilation or tachypnea, and this is where the end tidal CO2 is gradually decreasing and goes below our normal range. Generally, they'll have a faster respirate. It's a smaller waveform. It can be caused either by they are too light, or it can be pain related as well. So if you've probably seen it all the time, you go into like a bitch bay, they start incising and then they all of a sudden become really, really puffy. It can be caused because of that. Yeah, so pain, light plane of anesthesia. It can also be caused by overventilation as well. So if we're manually or mechanically ventilating our patients, they will get generally a normal waveform, but we could be giving them too much tidal volume. And then the treatment for this is, if they're painful, giving them some analgesics. If they're light, increasing our depth. And if we're ventilating them, reduce our rate or the amount of volume or pressure that we're giving. What do we think of these ones? So this top image, we've got two nice normal breaths and then we have nothing. And then this one here, it's one really long breath and kind of going down a little bit. Has anyone got any ideas on what this could be? Kind of, yeah. So it's apnea. So apnea is where we aren't breathing at all. So it can happen like this, where you have a couple of waveforms and then the patient just completely decides to stop breathing and it goes flat to zero. This one is one you might see quite commonly, and it's where you give a breath, but then your end tidal stays really high for really long. And it's just because they've just kind of continued to breathe out. So they actually haven't inspired anything. So sometimes your capnograph just keeps trailing down because there can't be any sharp baseline because they haven't breathed in any oxygen to make that happen. So you can see it in both ways. So this is, again, the absence of spontaneous breathing or our flat line. So if your ice is too high or you have any CRIs, or even if you've given any extra drugs, it can cause your patient to become too deep and cause apnea. So if you see these, check your patient. Make sure your circuit's still attached, because that is also one of a very common thing. You'll be like, oh, my patient isn't breathing, and then you look, and then your capnograph isn't even attached to your patient. Provide a manual mechanical ventilation. So actually just give your patient a breath and just make sure that then you get a normal trace from that. And then review any drugs given. So drugs cause our central nervous system depression. And if you've just, say, induced your patient, that can cause apnea. And if you've given any opioids or ketamine or any other analgesics whilst under anaesthesia, that can also cause a brief period of apnea as well. If you are giving any drugs, give them very slowly, because you may need to support them with breaths. Another cause for this as well is actually respiratory muscle fatigue. So as we've learned, the respiratory system is compromised of our diaphragm and both sets of our intercostal muscles. So if the patient has had severe respiratory effort, so sometimes in our brackies or any of our airway dogs, or any they have any respiratory disease, the respiratory system can get really fatigued the same way any other muscle does. So because of that, the muscles generate less force with each breath, our tidal volume decreases, and then our ventilation becomes effective. So from that graph that Francis was showing us earlier, they're actually just breathing through their dead space. They're not actually getting the air from kind of their mouth to their lungs, and it's not being able to take part in that gaseous exchange. And then if apnea does happen, just support with manual breaths, or if you've got a mechanical ventilator, use that. Watch your SpO2 and make sure that they're perfusing nicely. And if you've given any drugs such as propofol, Faxone, your opioids, etc., they are generally short-lasting. So support them while they're going through that period, and then you can try and kind of stop yourself from giving them breaths, and then hopefully they'll start breathing for themselves. On to our next one. So this, you can see that our plateau is quite sharp and it's very steep. Does anyone know what this is called or what it could mean? Pardon? Say it, Yes, exactly, a blockage. So this has got this very shark fin appearance. So this means there could be an obstruction of the airway or the ET tube. Sometimes it will look quite pointy. Sometimes you'll have like a start of an increase and then it plateaus up. So this is always because of a partial airway obstruction. If your airway was completely obstructed, you wouldn't get anything from your capnograph. So because this is a prolonged expiratory phase, so they're actually really struggling to then get those breaths. So it could be because of a kinked ET tube, could be caused by secretions and mucus. So with cats especially, they can get mucus plugs, and sometimes they can occlude the airway, sometimes fully or partially, and then bronchospasm as well. So if you've got any of your asthmatic patients or anything like that. First thing to do is check your patients. With big dogs, they can bite down on their tube, especially with those kind of staffy breeds. They've got such big jaws, they can kink their tube that way. With small animals and cats and very small tubes, if they're in an awkward position, they could have an actual kink in it. Especially in our ophthalmology cases as well, with most dogs, sometimes their heads are in these very weird positions and the tubes are in very weird positions, so they can kink that way. And also just have a look at your patients. Like if you're seeing this waveform, look at what they're doing. Do they look like they've got increased respiratory effort? Does it look like they're really, really struggling? If you observe a kink in your ET tube, just try and rectify it. If you can't see a kink, give the patient a breath yourself. See what happens with the capnograph. Does it go back to normal? when you did your leak test, does it feel like there's a lot more resistance than there was before? And if there is, consider suctioning it. If there's a mucus plug or anything, you can dislodge it yourself, or if you're really worried, extubate and re-intubate your patient. If you think it might be because of some bronchospasm, consider why. Does your patient have any history of being asthmatic? Are they having like a bronchoscope, or could any fluid of anything gone into their lungs and cause bronchospasm? And then consider giving a bronchodilator if you are worried. So you can give terbutaline, or a puff of salbutamol down the tube should help as well. So then we have this one. So this top image, as we can see, we're not going down to baseline. We also have a very high end tidal. And this one here, you can see we have gone a bit tachypnic, and then our waveform has gone in the middle. Do we have any idea of what this could mean? Anyone? It's fine. So this is rebreathing. So this is actually on a real patient, for which their soda line was not ever changed, on a circle system, and that's this number here. So as you can see, it says inspired CO2, which is 29. So this is really high. So it means that the patient is actively breathing in CO2. And then this bottom picture is where a patient has just gone so tachypnic, and hyperventilating that they're actually just not breathing properly. So they are just breathing through their dead space. So nothing is happening going down straight into the alveoli and actually having any gas exchange. They are just constantly rebreathing. We don't want our patient to breathe in CO2, and this number should always be at 0. We do tolerate it to about 3 or 4, and it generally means if you're on a rebreathing circuit that your soda lime has expired, and you need to rechange it, or if you're on a rebreathing circuit such as a BAME, TP, SLAC, that your volume of your gas is too low. So yeah, exhausted soda lime, inadequate fresh gas flow, and it can also mean that your expiratory valves aren't working properly. So one check to do before, when we leak test our circuits before every patient, one good thing you can do is when you keep your thumb or the cap on the end, once you've opened your APL valve, keep your thumb or cap on the end and squeeze your bag, because that will give you any indication if there's anything sticking, or if it doesn't feel like it's going through easily, then you will have something wrong with your expiratory valve, so that your patient can't breathe properly. If your patient is rebreathing and they're hyperventilating, just check your patient's depth first, because they could be sore, they could be light. They can also be hot as well. If your patient is hot, they will tend to pan under GA. So just check things and see how you get on. So I'm hoping the video on this works. So on this, you can see that we have kind of a step down. I don't know if you can hear it, but for every time the heart beats, we then get a new waveform. Does anyone know what this is called? It's quite a rare one. We only really see it in our tiny patients, or if they're really slowly breathing. But it's called cardiac oscillations. Now, fun fact, you don't see this in humans, because all the tiny humans that are on a capnograph are all ventilated, and we only see it in our patients. So it's quite cool. But this is caused by the mechanical movement of the heart during contraction, and it causes minor shift in the lungs, meaning that more air gets expelled out with every beat. And it will occur at the same time as your heart rate. So if you see a beat and like it go down and then it goes back up again, just listen out to your heart rate or watch your heart rate, and then it should be quite rhythmic. Sometimes, especially in like this bottom image here, it does also look like they are hyperventilating as well. If you are worried, give them a breath, look at your patient, see what they're doing. And as I said, it's commonly seen with our patients with low heart rates, low rest rates, not heart rates, or small tidal volumes. And then should we be worried about this? And the answer is no. It's normal, it's physiological. We don't generally need to treat it. And yeah, it's quite cool when it does happen. So this one kind of looks a little bit similar to our kind of hyperventilating, but has anyone seen, or does anyone know what this kind of trace might be? So we've got good end tidal, and then with every breath it's decreasing. And this can be a sign of respiratory arrest. So some people call it the waveform of impending doom. It definitely has made my heart go a couple of times, and it's not very fun when you do see it. But it's decreasing end tidal CO2, which may mean respiratory arrest. Generally, our patients will go into respiratory arrest before going into cardiac arrest. So our capnograph is vital in these situations because it gives us an idea before our ECG changes and things. So if you do start to see this waveform, first thing to do, check your patient and check that your capnograph is still attached. Check that the patient is pink and they're not looking kind of that bluey grey colour. And give your patient a breath. If your capnograph goes straight up back to kind of a normal value, your patient isn't going into respiratory arrest. If they were truly going into respiratory arrest, it would stay low. So it could mean that you've got cuff issues in your tube, your ET tube placement, or some hypoventilation. And as I said, if they've truly gone into cardiac arrest, you will then see your ECG change and things like that. The process of checking your capnograph and if they're pink and giving them a breath should take you about 10 to 15 seconds. And generally, I'd say 80 to 90% of the time, you'll be fine. And you're like, oh, okay, it's because the ET tube has become disconnected, or they're hyperventilating, or they've just got apneic, or that you've got your cuff in your tube has gone down. But if your patient has gone into cardiac arrest, and you don't already have an ET tube in, it confirms your tube placement. And as I said, it's one of our first warning signs. Then if our patient, we're doing CPR and it's all going really well, we see these kind of waveforms, it means that our patient generally has got a return of spontaneous circulation. So that means that we've got a heartbeat back. And the reason why it goes up so quickly is because then our perfusion and our circulation has gotten better. So all of our gases exchange is happening as normal again, and the patient ideally probably should have a beating heart. So rising end tidal CO2 that's quite sharp may indicate return of spontaneous circulation. Just to note with CPR and our capnography, we're aiming for a number of 18 when we're doing our compressions. So when we're doing our compressions and we're giving our breath, it is why it's so vital, is because it's actually telling us if our compressions are good enough. So if you're getting numbers of kind of 15 to 18, that means our compressions are great and we're actually getting some end tidal expiration, which means there is some circulation happening. And then we've got this one. It kind of looks like a mixture of everything that we have just talked about, which makes it slightly confusing. But this is kind of a leak in our ET tube. So with this top image, we've got a normal capnograph, and then it's kind of going a little bit funny. It's not great. With this one, it does make you think, are they going into slight impending doom? But it's just that there's air leaking around. And then the same with the bottom one as well. It's not quite a normal waveform. It's not technically a shark fin. It's kind of a bit of a mixture. But what it means is that there's gas escaping around our ET tube, and we'll generally find that if we're manually ventilating or the patient is completely relaxed after we've given our induction agent and it's truly relaxed on ISO, we might see this. And it's when the cuff doesn't have a proper seal in our trachea. So you can see reduced end tidal values, irregular capnograph, incomplete or distorted waveforms. and it is just caused by an undeflated ET tube. And just check your pilot balloon as well. Sometimes they can become detached so that then they're not actually doing their job anymore, or your ET tube is too small for your patient. So if you've inflated that balloon quite a lot and you're like, I can't inflate it anymore, and there's still this happening, it means you just need to extubate and reintubate your patient. Sometimes you might not even get a trace at all. If it's so small for the patient, you might not get anything. Oh, and patient positioning as well. So if your head is tilted kind of quite far back, sometimes it can cause leaks from the trachea as well. And again, this is a big mixture, so I won't put you guys too much on the spot. So again, we've got a hypercapnic one, and then we've got a waveform that looks like it has a complete mind of its own and doesn't know what it's doing. So this can mean increased abdominal pressure. So if you have increased abdominal pressure, it's harder to expand your chest and it's harder for the diaphragm to move. And obviously, as we know, our diaphragm is so important when it is in terms of respiratory rate. And because of that, we get reduced lung expansion, reduced tidal volume, and it causes some hypoventilation. We will see a gradual rise in our CO2. And with that, so the causes of it is if you're doing any laparoscopic procedures, so we're putting CO2 into the abdomen and making it bigger. So that puts a lot of pressure on the diaphragm, which can then cause this hypoventilation. And this top 174 was actually doing an endoscope. So the stomach was ever so slightly too dilated, so they really, really struggled to breathe. And also if you have high abdominal pressure, so if you've got your GDVs, because it's, again, the stomach's so expanded and it's quite close to the diaphragm, so it's going to push up against it. Any cesareans, or in general, even our pregnant patients, again, because they've got so much volume in their abdomen, it pushes up against their lungs. And then abdominal retraction. So if you are in an XLAP and they've really cranked open that abdomen, it can make it harder for them to breathe as well. And our obese patients. So in these patients, would definitely recommend tilting the table so that their head is up. That just helps gravity do some of the work for you. You may need to ventilate your patient as well. And this bottom image here is actually from surgeons putting their hands in a cat. So you've probably seen it before where you're like, oh, why is my capnograph gone really strange? And it's actually just because their hands are so big that they move everything around, or any pressure on the abdomen or anything like that. So it's always really important to just talk to your surgeons and be like, oh, can you just stop what you're doing for a second? Or just explain to them that you're getting some weird capnographs and you're not sure what to do. If you're concerned as well, you can just start to ventilate your patient. Make sure that you get a relatively normal waveform. So just our key takeaways, because I understand that was quite a big talk. Capnography is our ventilation monitor, and it's very, very vital for us. The waveform and the shape is so important, as well as the number and monitoring our trends. If you have one random breath of low or high, just check it. And it is our best warning tool in our emergencies. And especially with side stream, just remembering there is about a 3 to 10 second delay. So be patient. If you're not seeing anything, you've just seen your bag move, but you've not seen anything on our waveform, just give it a moment. They're slow sometimes, but they are really, really great tools. Does anyone have any questions? Oh, that's great. Thanks, guys.
Thank you. Yeah, I think it's had the lights on, so that we'll be around. Scary moment. Don't forget to push over. Yeah. There we go. So thank you everyone for coming. Please feel free to get a couple of snacks. Please try and find your name. If you haven't registered, you can let us know your name and we can do all now. If you're missing, I think I got everyone. And as Kelly said, we've got some little like lanyards with different capnographs and what they mean. So I'm carry those around with you. But then we also have some posters to put up. all the information and some magnets and leaflets. Help you just.
Yeah, we're going to record. Yes, we've recorded the whole session and we're going to publish it. Okay, for everyone online, I'm going to stop sharing my screen and turn the mic off and end the meeting. Hope you all enjoyed it and thank you for coming.